All right. Good morning, everyone. Thank you so much to Barry for the invitation to come and speak, and thank you to everybody who braved the snow this morning and was willing to come out and hear me speak. So welcome. Welcome to the Althouse College. I've been here many times. In fact, the last time I was here, I was on stage, and as you mentioned, I was doing my medical training here. And some of you may be aware of this small little production that they run every year called Tachycardia. Remember, what happens at Althouse stays at Althouse. Okay, so I need to change windows here so we can get started. Okay. Great, so I've been asked to talk to you about my research area. And certainly I see lots of patients clinically as well who have osteoarthritis. Rheumatology is an area that focuses on autoimmune diseases. Probably the canonical disease that we would see would be rheumatoid arthritis, and I'm sure lots of you know exactly what that is. But osteoarthritis is by far the most common type of arthritis in the world and has the fewest treatments available. So we're doing a lot of research in this area. So I wanted to particularly focus on some of the things that we're doing here at Western, and I should point out right away that we're integrated in a network across Canada and also internationally among people who are doing research in osteoarthritis as well. So even though we have a lot of things that are focused here at Western, and we have a lot of expertise in the Bone and Joint Institute here at Western, which is very exciting, and in fact probably the main reason that I came back to Western, we certainly are part of a much larger community, which is becoming more and more connected all the time. I also wanted to touch on why you are all here. And I didn't really know anything about this until I was asked to speak in this lecture series, and I was incredibly impressed to find out that this has been going on since 1977. And most of you have probably known this for a long time, but I learned about Dr. Ralph Devereaux, who actually founded this lecture series, and you can tell from his background, incredibly engaged in education and really interested in helping people learn more about the world, not just in psychology, but certainly in all areas which this series has helped to underscore. From Kent County, was actually initially a teacher working in Windsor in the Great Depression, and then joined the RCIF and served in World War II. He founded the Teachers College and integrated it with Windsor University in 1972, and then retired in 75. And so this is a long-standing series. So I'm really honored to be here and asked to be part of this. And looking ahead at all the other lectures that are coming, you guys are in store for yet another great season. And I wondered if maybe I could just join. I mean, I'm a Western alumni, right? So I should be allowed to come and do this, but it's a 5-year wait. So maybe I'll wait a few years. Okay, this is the work plan this morning, and I guess we're gonna talk for about 45 minutes, and then we have a break, have some coffee, and come back and discuss, which I'm looking forward to. So this is generally the outline. I want to convince you that osteoarthritis is a big deal. It's an overwhelming problem, actually, a huge burden on society. We'll talk about the medical treatments and non-medical treatments that are currently available and what we need to establish in the years ahead. I want to talk about all the different drivers. I don't think there's any disease that really exemplifies how important it is to collaborate and work together with groups with other expertise than osteoarthritis. It's so multidimensional, and it needs lots of incredibly intelligent people working on this. And then I'll talk to you about what's near and dear to my heart. I'm a rheumatologist. My expertise is in inflammation and autoimmune diseases, and so we're adapting that expertise to understand really new and exciting things about osteoarthritis and hopefully a window to some new treatments available. So that's what I'm going to try to cover. So have a look at your hands, and then look at the screen. I want to point out that osteoarthritis comes in a wide variety of shapes and sizes. This is a particular type called erosive osteoarthritis. And you can see that there's actually quite a bit of swelling, so inflammation, in particular around certain digits at the tips of the fingers. And this is something that we see in a particularly aggressive form of osteoarthritis called erosive OA. Obviously very painful, has a big impact on people's quality of life, ability to eat, dress yourself, so on and so forth. But of course it affects other joints as well, and osteoarthritis can affect the knees. I hope you can appreciate by looking at these two knees that they're not the same. This one has quite a bit of inflammation above it, some swelling above the knee. And I'm going to come back to why inflammation is so important in osteoarthritis in a little while. But this has a big impact on people's ability to get around in the world. And if you don't have your mobility, you don't have your independence. If you don't have your independence, quality of life goes way down. When we think about osteoarthritis as a disease, we think about what's happening at the tissue level. So we look at a healthy joint here on the left side, and on the right side you'll see an osteoarthritic joint. And in a healthy joint, we have nice, smooth, articular cartilage. That's the cushion tissue on the ends of the bones that allows the joint to glide smoothly back and forth. There's a nice, healthy lining of the joint called the synovium. And there's also, obviously, the bones themselves that are nice and smooth and organized. But in osteoarthritis, people often think about cartilage damage, loss of cartilage at the ends of bones, and certainly we see that as a consequence of the disease. But what's becoming increasingly more important is inflammation in the lining of the joint, called synovial inflammation or synovitis. And this has kind of been set aside because when we think about inflammation and arthritis, people always think about rheumatoid arthritis, and it's an aggressively inflammatory disease. But the inflammation in osteoarthritis is much less understood. So just keep this in mind as we go through today. I want to touch on the burden of osteoarthritis. So how many people, put your hand up, I can see. They told me to just step into the light. I wasn't sure what that was supposed to mean. But I can see this half and 20% of you. So just put up your hand if you think that of all the adults in Canada over the age of 20, what percent do you think have osteoarthritis? Hands up if you think it's A, 6% of all adults. How many people would say B, 11%? How many people would say C, 14%? D, 19%? And E, 26%. I think some of you voted twice. Okay. Maybe I've sort of biased things, but in fact, the answer is 14%. It's the second most common chronic condition of all Canadians. And remember, I said people over the age of 20. And most of the time, people think about osteoarthritis as a disease of the elderly. There's certainly lots of osteoarthritis among elderly people, which I think is over 95 nowadays, I'm pretty sure. This is pretty fresh Canadian data from the Public Health Agency of Canada. So about 14% have osteoarthritis, a big, big problem. But I really like this data. This is global data from the World Health Organization. So the Global Burden of Disease study studies all kinds of chronic conditions around the world and tries to compare where they are. But it also looks at where these things occur in people's lifespan. So it's a bit difficult to see these here, but the shape of the curve is really all you need to see. This is age 0 on the bottom, age 20, 40, 60, 80, age 100. And I just want to point out that symptomatic osteoarthritis really starts to take off by about age 30 to 35. And most of the new cases of osteoarthritis are happening between 40 and 50. So when you think about osteoarthritis as a disease of the elderly, think about how long people have been living with this disease before they became elderly. Most people who get osteoarthritis are actually active in the workforce. So the majority starts between age 30 and 55. This is a complicated table looking at symptom scores, and it's brand new data out of Rush University, and it actually compares the symptom burden between patients with osteoarthritis and people with rheumatoid arthritis. And so regardless of whether you're looking at functional scores, pain scores, overall global assessment scores, at the first visit, the magnitude of these scores, meaning the severity of pain and stiffness and function, is basically the same between rheumatoid arthritis over here and osteoarthritis here. But whereas rheumatoid arthritis scores tend to get better over time, because guess what? We have great treatments available, osteoarthritis scores don't get any better. So the burden of the symptoms is comparable to rheumatoid arthritis, but we don't have the treatments available. It's by far the most common type of arthritis in the world. I've been showing this slide since 2012. So back then, this was relatively new data. We said, okay, there are 10.5 million people projected by 2020. Guess what? It's 2020. So here we are. And at that point in time, they were saying about $27.5 billion of the Canadian economy was dedicated to osteoarthritis care or loss of productivity. Fast forward 10 years later, you can expect this number is about twice as high. So this not only has a huge burden on patients, but also has a huge burden on society, on our healthcare system, and just on the productivity of our workforce. When you look around the world, we look at diseases that cause disability. That's probably the main outcome of osteoarthritis, is causing disability, which lowers your quality of life. The World Health Organization ranks conditions by the number of years that people live with disability. And out of 291 conditions, osteoarthritis is number 11 on that list, which actually ranks higher than tuberculosis around the world and higher than cardiovascular disease. So it's a massive problem. And until 2017, this was actually not recognized by the FDA. Remember, the Food and Drug Administration in the United States approves medications for use in the United States. In Canada, it's Health Canada, but typically Health Canada follows suit from whatever the FDA does. So a group of people, including Jill Hawker, who's a rheumatologist in Toronto, and Lynn March, who's an osteoarthritis researcher in Australia, got together and put together a 300-page white paper, tabled this to the FDA, saying that osteoarthritis should be a major health priority. And the benefit of this was that in 2017, the FDA actually approved osteoarthritis for fast-track status, meaning it's a serious disease. And that's important because now, if there's a new medication that's being studied for osteoarthritis, it gets put to the front of the line for review by the FDA instead of languishing for years waiting for review. So as a serious disease, it can now be prioritized. So this was huge for our field. I also want to address something else that's particularly important. One is that people sometimes feel a little bit nihilistic, if you will, about osteoarthritis. It's just osteoarthritis. I'm just getting older. Or even in the healthcare field, let's be honest, some people sort of say, oh, it's just arthritis. There's nothing I can do for that. But when you talk to patients, they tell you something different. They ask, I just wish somebody could do something for me. I can't even go visit my son because I can't get into the house. Or nowadays, there are amazing treatments available for cancers. Why can't I just have cancer? Because then at least they can treat that. These are real quotes that people have said to me in my clinic, and I'm sure people have said this in clinics across Canada. I think we can do better than this. And so that's really what I want to talk to you about today. So today, if you walk into a clinic, you can expect that there are treatments available for you to help reduce your symptoms and improve your function. So the Arthritis Alliance of Canada, Centre for Effective Practice, and the College of Family Physicians got together and put together a tool, a summary tool, to help family doctors, orthopedic surgeons, rheumatologists, sport medicine physicians to adhere to all the evidence-based options that we have available. And that's just shown up in this table here. I'm not going to go through every single treatment that there is available, but the point is that these are evidence-based. There are good quality trials, good quality scientific evidence that says that these can offer a meaningful benefit in terms of lowering symptoms and improving function on a daily basis in people who have osteoarthritis. And these are things that you probably already know. Just lose 5% body weight. That's 5 pounds per 100. Physical activity, 30 minutes of low-intensity exercise 5 days a week can meaningfully reduce symptoms in osteoarthritis. And in particular, neuromuscular control exercise. Most people don't know what neuromuscular control exercise is, but instead of it being endurance running or lifting heavy weights at the gym to try to get stronger, this is just about trying to improve control of the muscles around the joint. And so there are programs like the GLAAD program, which I'll show you in a minute. But any neuromuscular control exercise like yoga, like any physiotherapy that involves balance, these things are going to be effective, evidence-based. And there's lots of analgesic therapies, topical NSAIDs are certainly safer than oral NSAIDs, things you take by mouth. Acetaminophen has a small benefit. Some people find it's effective, others don't. This is one that's actually very underutilized, but 3 good clinical trials showed that there's a meaningful benefit to duloxetine. The limitation is some people don't tolerate it very well, and it's really not prescribed very often. Just to touch on opioids, lots and lots of people, in fact, about 38% of patients with osteoarthritis are currently taking narcotics, opioids, in Canada. And there's a massive opioid crisis going on, lots of diversion and all those things that you see in the media all the time. In fact, opioids are not recommended for osteoarthritis. It's a very, very small percent of people who get a meaningful benefit from it because it's chronic pain. And opioids were never designed for chronic pain. They're effective for acute pain. So they're actually not recommended, with the exception of tramadol, which is a very weak opioid. And then corticosteroid injections, which most people think of as a cortisone injection. These are effective for short-term relief of symptoms, but they don't change the long-term outcome. So all of these treatments are available and very underutilized. In fact, I would say it's less than 5% of patients who come to my center get referred into a specialist who have tried even half of these options before they get referred on. So I think that's something we can do much better on. I mentioned the GLAAD program. This was actually developed in Denmark. That's the D in GLAAD. It stands for Good Living with Arthritis in Denmark. But if you put the tagline Canada on there, you can use it in Canada. GLAAD is a neuromuscular exercise program. It's a 10-week program. You can go online. You can go to glaadcanada.ca, find out where there's a center nearby. You can self-enroll, and you can participate in this. And this is evidence-based. This has actually been trialed against joint replacement surgery and was more than half as effective as a joint replacement. In fact, there were 20% of people who were on the surgery list and within 2 years still had not gone for joint replacement just by doing this. So this is something that we can certainly do better at, I think, as well, is get the knowledge out there to people to know that they can take control, that they can make a difference. You're not going to change the long-term outcome. That's not the point, but you can live better. Okay. Well, what we'd really like to have is a disease-modifying drug. And a disease-modifying drug is one that can actually change the long-term outcome. We don't have that right now in osteoarthritis, but to define what that is very important. We need to know what we have to change in order to call it a disease-modifying drug. So in addition to improving symptoms, pain and function and stiffness, you would also need to be able to show that you have less damage, less progression of the arthritis over time. So this is what you would call a disease-modifying osteoarthritis drug, or a DMOD. These are disease-modifying treatments that are currently available to treat rheumatoid arthritis. We have 18 approved, meaning they've gone through clinical trial development, been approved by Health Canada, and are effective at reducing damage and stopping progression of rheumatoid arthritis. This is part of the reason it's so much fun to be a rheumatologist, because people with rheumatoid arthritis come in and we can make them better. Unfortunately, in osteoarthritis, we still don't have a disease-modifying drug. And there are lots of trials going on, and we're involved in some. So we have lots of hope, but we're still not there. Why has it been so difficult? Why is this disease so difficult? Maybe we're just not trying hard enough. I don't know. I think one of the most important reasons is that osteoarthritis is a multidimensional disease. There are multiple things that drive this disease forward. So you can't just target one thing, okay? Or in other words, it's complicated. Whatever Merrill says goes, right? the multidimensional aspect of osteoarthritis is particularly interesting. We've always known that osteoarthritis is driven by abnormal biomechanics, or the way you move. This can damage tissue, not just acute joint trauma, but chronic abnormal movements, things due to malalignment. So if your knees are pushed out too far, so bow-legged, or in too far, knock-kneed, those sorts of things can contribute to progression. And we know that there are genetic risks, and aging I still haven't found a cure for. But there are lots of things we now know about the different tissues involved. And it's not just a cartilage disease. We know that there are problems in the cartilage, but also in the bone. There are changes in the central nervous system and the peripheral nervous system, changes in the meniscus, the muscle, the tendons, and the ligaments. And in particular, what we're seeing more and more now is chronic inflammation. And so when you have chronic inflammation, that actually makes these tissues more susceptible to damage. When you've got abnormal biomechanics, the susceptible tissue gets damaged, and these things feed forward onto each other. So interrupting this cycle is really, really important. And what we're coming to understand now is that interrupting the inflammatory component of osteoarthritis might be a key. Another reason that osteoarthritis is difficult to develop disease-modifying treatments for is because it's so heterogeneous. People come with really different kinds of presentations. I already showed you hand osteoarthritis and knee osteoarthritis, and they're not just different because of the location. The hand osteoarthritis was erosive, and the knee osteoarthritis is not. So there are different risk factors that contribute to why people might get, say, knee osteoarthritis, for example. Obesity and metabolic syndrome, aging we already touched on, and joint trauma. These sorts of things make each person different. Some people have more mechanical problems. Other people don't. Other people have almost no mechanical problems, and yet they have chronic inflammation and knee osteoarthritis. So comparing people is actually very difficult. There's a test on this afterward. I just want to focus on the concept here. The joint is actually an organ, just like a kidney. And so to think of the joint as just a cartilage tissue is probably where we've kind of gone wrong over time. Remember I showed you healthy joint before, osteoarthritic joint on the right-hand side here. We now know a fair bit about the biology of what's happening in the cartilage, in the bone that underlies the cartilage, and in the lining of the joint, which is called the synovium. And what's really interesting is that when the cartilage starts to break down, these matrix products, so little tissue fragments, will break off and can actually, they're microscopic, they can bind to inflammatory cells and activate your immune system. And so this may be one of the key reasons that chronic inflammation is seen in osteoarthritis, which is different than rheumatoid arthritis, isn't it? So in rheumatoid arthritis, you lose immune tolerance. You develop autoimmunity against your own tissues. So it's sort of the other way around, where the inflammation now starts to attack the joint. And here, the joint is actually creating inflammation. And the final reason I think that's really important, that we really need to start changing the way we approach clinical trials, is that we've been focusing so much on late to end stage osteoarthritis. We have amazing treatment for late to end stage osteoarthritis. It's called a joint replacement. And before joint replacements, people used to die in bed with their arthritis. So this was a huge advance in the 50s and 60s, and certainly the technological advancements that have happened in surgery have been amazing to help give people a major improvement in their quality of life, even if they have end-stage disease. But joint replacements are no good for early-stage disease. And if we want to prevent people from getting to end-stage disease, we need medical treatments. And early osteoarthritis is actually arthritis that happens before you have a lot of damage. These are x-rays, and what we see over time is worsening of damage that can be measured by x-ray. So in very early stage disease here, this is your femur, your leg bone, the tibia, the lower leg bone. We see nice black space in here, which actually is where the cartilage lies. But as time goes on, excuse me, the joint space here, which is the cartilage, actually gets narrowed. So we see damage and loss of cartilage. And notice too that the bone gets a lot thicker and quite deformed. So why is it that we actually enroll patients in clinical trials who have this much damage? Almost every single clinical trial that's ever been done in osteoarthritis involves people at this stage of disease. We're not going to turn back the clock. I think we need to be focusing much earlier. So this takes a rethink in terms of what we're doing in clinical trials as well. So the new approach is needed. I think we need to treat the entire patient, not just the disease. We need to look at all the different risk factors. What are your mechanical risk factors? What are your metabolic risk factors? How much inflammation do you have? I think we need to treat earlier before there's major joint damage. And it's possible we may actually need to combine therapies. And in fact, in rheumatoid arthritis, combination therapy is the rule, not the exception. It's the rare patient who's able to be on one medication. Most people need multiple. And with a complicated disease like osteoarthritis, I think it would be a big surprise if that was any different. So we may need anabolic therapies to help restore tissue, but we probably need anti-inflammatory or even anti-rheumatic therapies, bone therapies, and certainly therapies that are targeted at pain. So that's why we've established the Western Rheumatology Center for Osteoarthritis. This is out of St. Joseph's Hospital. That's where the Rheumatology Center is. But we're actually a multi-site clinic, and we collaborate with the Fowler Kennedy Sport Medicine Clinic, the Rohrbeck-Born Arthroplasty Clinic at University Hospital, and this is the Wolf Orthopedic Gait Lab on campus. This is one of our students, Cody, who's walking through the lab doing a gait test. Gait analysis measures all the different angles as you walk through the lab, and you can see these cameras around the room. They're actually measuring the angles at the knee and the ankle and the hip and the rest of the body. And this tells us about the biomechanics of the person with arthritis. So we do gait analysis in this. We also obviously follow the evidence-based goal-directed therapies for osteoarthritis management. We use musculoskeletal ultrasound to help tell us about how much inflammation there is inside the joint. And we collaborate with orthopedics and people who have malalignment, because some people have so much malalignment that they actually need to have their legs straightened. That's called an osteotomy. In fact, this center is the biggest center in Canada and the third biggest center in North America for osteotomy procedures. We have lots of expertise in musculoskeletal health here. And of course, we're doing clinical trials as well with candidate therapies for disease-modifying treatment. So what we're really trying to do is address all of these factors. We're trying to fix the biomechanics, we're trying to target tissue-specific processes, and address chronic inflammation. So we really need new targets for therapy. And if the joint is an organ system, we're going to have to think about how we find new targets and what those are most likely to be, which ones are going to be most effective. So I'll draw your attention to the synovium, where the chronic inflammation is, where the cartilage is, and where the bone is. And so I want to point out something that I think is a really key observation for the osteoarthritis world, and it was just published in October of 2019. We've always thought of osteoarthritis as a cartilage disease. So people have always wanted to go into tissue engineering and re-engineer cartilage so it can be implanted in a joint. And more recently, people have taken the approach that they just want to try to regrow the cartilage that's there. So one of the things that we've learned about cartilage is that there are biological mechanisms that can be exploited to try to increase cartilage thickness. So the FGF signaling pathway, or fibroblast growth factor signaling pathway, is really important, especially when you're growing up. You need this signaling pathway to increase the amount of cartilage that you have. And as you're growing, you go through this process of actually replacing the cartilage. So the chondrocytes, which are the cartilage cells, proliferate, get bigger, calcify, and then get replaced by bone. This is the normal program. But then when you become an adult, you need to stop growing. And so what's supposed to happen with FGF18 in particular is stop this cycle, arrest the chondrocytes so that you have mature cartilage on the ends of your bones. And osteoarthritis actually inhibits this process and kicks the cells back out so they get replaced by bone. So some really smart people said, okay, why don't we just look at FGF18? Why don't we just inject FGF18 into the joint? So there was this big trial called the Forward study, and they had 549 patients who received different combinations of these treatments or a placebo injection for up to 2 years. So an injection of this recombinant FGF18 protein into the joint once every 6 months or once every 12 months at a low dose or a high dose, compared that to the placebo, and followed them to see what would happen. And so this was just reported in October of 2019. What they found was that the black line, where the people got the highest and most frequent dose of this FGF, was that it worked. It thickened the cartilage. First time this has ever been shown in humans. Really amazing. The people who didn't, so being the people who got the placebo, their cartilage just continued to thin over time. So it worked. But don't forget about the patient. Their pain scores didn't change at all. This is not just a cartilage disease. You can't just repair cartilage and expect everything to be okay. And that's the point. This is an organ system. So if you're going to try to repair cartilage and grow healthy cartilage, you need to fix the environment. And if you were going to try to plant a pumpkin and grow a pumpkin, you wouldn't plant it in the desert. It's too hostile of an environment. So what we need to be doing is thinking, how can we fix the environment of the joint so that tissue can actually heal? So this is where our interest in rheumatology, and my interest in particular, is in chronic inflammation in osteoarthritis. If the inflammation is creating a hostile environment, we probably need to treat that if we expect the tissues to heal. We can measure inflammation inside the joint with imaging. So we can use MRI. MRI shows you this white signal up here, which is underneath the kneecap and on the sides of the joints. This is chronic thickening due to inflammation in the lining of the joint, call that synovitis. You can also measure it with ultrasound. This is your leg bone down here, the kneecap is up over on this side, and all of this fluid and chronically thickened tissue inside the joint is the thick tissue, the inflamed synovium. So we can measure this, and we do this in the clinic all the time. Does this inflammation matter? Well, yeah, it does. And in fact, this is a beautiful study done with about 7,000 patients in the United States called the Multicenter Osteoarthritis Study, or the MOST study. Lots of jokes you can make with that. And what they did was they looked to see who had inflammation and who didn't, and whether people were more likely to progress on to damage or not. So they ranked people based on how much inflammation they had, just a little bit of inflammation, a little bit of white signal, or lots of white signal, so low, moderate, severe inflammation, and they gave them a score. And with some important statistical methods, they were able to show that if you had only a score of 3 out of 9, you were twice as likely to go on and develop damage on an X-ray within 2 years. And for each point you added on top of that, you increased your risk by another odds ratio of 1.1, so effectively increasing by about a third each time. So what they concluded is that synovitis, which is chronic inflammation in the knee, is an important risk factor for future damage. But that's just damage. What about pain? So they also looked at pain in these individuals. This is a different paper, same study. And they looked at the risk of having at least moderate pain in people who had chronic inflammation compared to people who didn't. And it was overwhelming. The people who had chronic synovitis were 9.2 times more likely to have at least moderate pain. So this chronic inflammation that's been ignored for so many years seems like it actually is really important. It's associated with joint damage, it's associated with pain, can we actually target this inflammation and try to improve people's outcomes? I'm a rheumatologist, so I'm totally biased. Of course, I think we can. This is a study that shows it. This was done by Dave Felsen in the United States. He's at Boston. Probably one of the most well-known osteoarthritis researchers in the world. And what they did was they looked to see whether you could change synovial volume using MRI to follow that with a treatment. So they injected people's knees with a corticosteroid, because this is a powerful anti-inflammatory. And what they did was they looked to see how many people responded in terms of pain, first of all, and then looked to see how much their pain improved. So the people who responded had a drop of almost 2,000 cubic millimeters, that's a large amount of synovium, if they had an improvement in their pain. And then they followed them for 6 months. And the people whose pain came back, they also found that their synovial volume came back. And the people whose pain did not come back, so they were sustained responders, their synovial volume actually continued to get better. So this is a responsive target. It's something we can actually aim to treat in osteoarthritis. And that's what they concluded. So we need to figure out the best way to treat chronic inflammation in osteoarthritis. And if we can, this may actually be key to creating a favorable environment so that the tissues themselves can heal, to reducing pain, to improving people's function, and hopefully, don't want to scare any of the orthopedic surgeons, but maybe reduce the need for joint replacement. I work with lots of orthopedic surgeons, and they're amazing people, and I love needling them about this, but we need them badly. What's the movie?
The Holy Grail.
Monty Python, right? Okay. This is the Holy Grail. That's what we're looking for. We're looking for a way to modify inflammation in osteoarthritis. And so I just want to summarize for you some of the new work that we're doing just before we finish here, so you can understand what we're doing at Western and what we're part of nationally and internationally. So I'll start with where we're looking at just understanding the mechanisms involved in inflammation and osteoarthritis. So we're particularly interested in inflammatory cells that exist in osteoarthritis. Remember I said the joint becomes inflamed, so we're targeting the inflammatory cells or immune cells that exist in the lining of the joint. The reason this is important is because it was shown almost 15 years ago now that macrophage cells, which are white blood cells that actually live inside the joint, are recruited very heavily to the joint from the blood in osteoarthritis patients. And so in this study that they did in Ireland, they showed that this brown stain, which marks the individual macrophage cells, there were a lot more of them, and they were associated with a large increase in the number of blood vessels inside the tissue. And what was particularly interesting is when they compared people with early stage osteoarthritis to late stage osteoarthritis, the people with early stage were actually more responsive to inflammatory stimulus. So it seems like the early stage of disease is even more inflammatory, and maybe over time it seems to burn out a little bit. So why macrophages? Well, macrophages are actually the Pac-Man, if you will, of the immune system. Does everybody remember Pac-Man video games? Yeah. I'm old enough to remember that. Pac-Man ate all these little dots, and that's exactly the job of the macrophages in the immune system. Their job is to eat debris, eat particles, and even eat bacteria. So they'll recognize a foreign particle, consume it, put it in this little vesicle inside the cell, digest it into small particles, and then expel it. Really neat cells. We're particularly interested in understanding how these guys act in osteoarthritis. And what's particularly neat about these cells is they can actually come in two varieties. They can be pro-inflammatory. They call those M1 cells. So they actually increase inflammation. This is important if you've got a virus or bacterial infection. You need to increase inflammation to try to fight that off. But they can also come as anti-inflammatory. And that's particularly important in wound healing. You need these guys to go away and the other anti-inflammatory macrophages to come in so you can heal. So we need to know why these macrophages are in the joint and whether they are more pro-inflammatory or anti-inflammatory. Ideally, you would have a treatment that would actually shift these macrophages from a pro-inflammatory state to an anti-inflammatory state to help improve healing inside the joint. So we've embarked on a project, a collaboration with a chemist here at Western. Her name is Dr. Gillies, Beth Gillies. Some of you may have actually seen her in the news recently. And it's for her work and some of the work that we're involved in drug delivery. One of the problems with any drug, any medicine that you give, is that it often has off-target effects. It goes and has effects on other cells or other tissues that you don't want it to. So what we're wondering is if, because these macrophages will recognize and eat particles, can we put the drug inside a particle and just send it to the macrophage by itself and not affect any of the other tissues around it? So with Dr. Gillies' help, we've actually been able to make these very microscopic, they're at the nanoscale, what are called liposomes, so lipid particles that contain drug inside them. This is an electron micrograph showing these particles, and that's the drug inside in crystal form. So we can now take these particles and put them into joints, and they will selectively go to the macrophages, allowing us to take a macrophage and instead of allowing it to go down into this pro-inflammatory state, shift it into an anti-inflammatory state. So we're testing this, and one of the ways that we test any kind of new intervention is, first of all, to try to model it in animals. Safer that way before we go into humans. So we use multiple different animal models. We often use a rat. So we have a rat model of osteoarthritis that's induced by surgically cutting the anterior cruciate ligament inside the knee. And the animals will, over a period of several weeks, develop osteoarthritis, cartilage damage and inflammation inside the knee. So this is very useful because very quickly, over only about 3 months, we can understand what the effects of these treatments are. So we do the surgery and start administering the inhibitor. And this is work that's being done by Yu La Zhao, who's a master's student in my lab. And so what she's done is she's actually developed 4 different treatments. She's got a control treatment, which is just a vehicle. Oops, I don't know what I did there. Just the vehicle. And there's this thing called clodrazome. And that actually just kills the macrophages. That helps us understand what happens if you just get rid of them altogether. She's got one with a STAT1 inhibitor, which actually blocks the pro-inflammatory macrophage. And so we can see the opposite, one that actually blocks the anti-inflammatory macrophage. And what she's been able to show is that if you give the active treatment, you can completely turn off the inflammation in the tissue. Over here with the vehicle, so the control, we have lots of inflammatory cells. Over here, the inflammatory cells are gone. There's no impact on the fibroblasts, the blood vessel cells that are over here. It's just targeted to the inflammatory cells. So we were very excited to see this. So we're actually moving forward with human studies, and we're moving forward with additional animal studies to see whether we wait longer or to see if certain other treatments that we're interested in can even give us bigger results. So stay tuned about that. We're also doing things in the clinic. We're trying to understand what happens to people over time who have chronic inflammation. And one of the things we wanted to understand is, does inflammation actually change how we walk? Remember, it's all about mobility, lifelong mobility. Our goal and our vision is to give everybody lifelong mobility. That means we need to treat the arthritis. So we wanted to understand how important inflammation is to controlling how people walk, their gait. So we've been following people for the last 3.5 years in this study called the WARIO knee study, which stands for the Western Ontario Registry for Early Osteoarthritis. It's our knee study. So we have people with early stage disease, people with late stage disease, or end stage disease even. We have some healthy control people so we can understand the difference between normal and abnormal. We measure inflammation in the knee with ultrasound, as I mentioned before. This is what chronic inflammation looks like on ultrasound. So lots of fluid accumulating, increased blood vessel formation, and chronic thickening. This work's being done by Ryan Pinto. He's a physiotherapy and PhD student, combination program student, working with myself and Dr. Birmingham, who's a gait biomechanist here at Western. He directs the gait lab that I was showing you pictures of. So what Ryan's been doing is comparing people with early stage osteoarthritis to late stage osteoarthritis. So he had a group of people with early stage and late stage disease. These are just their demographics here. But they all had a high level of inflammation based on their ultrasound assessments. So we actually gave them injections of corticosteroid in the knee to try to reduce inflammation and look to see what the impact would be on how they walk, on their gait. He confirmed that people with early stage osteoarthritis had a big reduction in the amount of inflammation that they had. But what was surprising is that the people who had late stage osteoarthritis actually didn't have any change in their inflammatory scores at all. Suggesting again that early treatment to try to modify the inflammation is probably more effective. And then he did all of their gait kinematics. This is how measuring all the angles of how people walk. And what he found was that this thing called the knee flexion excursion, which is how much your leg goes out when you walk, if you have chronic inflammation in your knee, you actually can't fully extend it. And so you walk like this. But when Ryan measured how these people responded, the people whose inflammation went down were able to fully extend their knee. And so they were able to walk normally. But the people who had late-stage osteoarthritis didn't have any improvement. So this tells us that early treatment is pretty important. We need to be intervening earlier. This is my public service announcement. This study goes for 10 years. And we need lots of healthy people to compare to. If you're interested, feel free to reach out. The very last thing I want to tell you about is our clinical trials program. I'll just tell you about one trial. We have multiple on the go. So we're trying to understand if we can modify inflammation, can we change people's outcomes? We just kind of showed you with this interventional study with an injection that we can, but we need a treatment that we can use in the long term. We can't use corticosteroids all the time. So we need highly effective treatment that will provide long-lasting benefit. This clinical trial is a phase 3 double-blind controlled trial of a medication that you probably have already heard of. It's called Humira. We use it to treat rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, Crohn's disease, ulcerative colitis, psoriasis, hidradenitis suppurativa. There's all kinds of diseases that have approved indications to treat with medications that target inflammation, like Humira. So we have people who have chronic knee osteoarthritis, and they also have chronic inflammation. So they've been selected for having chronic inflammation. And they're getting randomized to a placebo or Humira and getting treated for 16 weeks. They have an MRI at the beginning and after 16 weeks of treatment, so we can see how much inflammation improves. And of course, we want to see what the improvements are in pain, stiffness, and function. We've reached about 60 so far. We need 100 to actually answer the question. So these are the kind of things that we're involved in. We are one of 11 sites across Canada running this study. So we're very much tied into the osteoarthritis community across the country. And we anticipate this should be reading out results in early 2021. So just to summarize everything I've told you today, OA is a huge problem. It's the most common type of arthritis, has a huge burden on people, huge burden on our healthcare system, huge burden on society. But don't give up hope. I think there's a bright future ahead, and there are things we can do today. You can actually get evidence-based treatment to help improve symptoms at least. And we need new research to try to achieve better outcomes. I think we need to treat the entire patient, so all of the factors that are going on, not just the disease itself. Treat early, And I think inflammation is pretty important, and that's why our work ongoing here at Western is pretty exciting for us. So I want to just acknowledge a few people. Probably most of you, when you came in today, you never heard of me before. And that may be because I'm actually better known as Sonia Gustafson's husband. You knew that. I know you knew that. Or if not, then the father of these guys over here. And I just put up this acknowledgement because I think it's really important to point out that these guys give up some of their family time so that I can be involved in these sorts of things, and I really appreciate that. And this is some of my team anyway. So I've shown you some data today from Zhao. She's a master's student that I was telling you about her work with macrophages, and Ryan Pinto, who's a PhD student and physiotherapy student doing the gait work with us. And there's a lot of other people who work on our team. So they're listed up here. I need to acknowledge the funding agencies we're very blessed to have. It's a very difficult research climate right now to try to get funding. We've been very fortunate about that. And so I want to thank them. But I think probably finally and most important is I want to thank the patients who are dedicated to this work that we're doing. We absolutely could not be doing any of this work if people weren't committed to the idea and wanting to be involved in research. So thank you to them. And thank you to you for coming and wanting to listen. And I'm really looking forward to the discussion after this.